I've got a macaque monkey up here because the middle line refers to a study. Well, sorry, I should say first, Jeffrey Lieberman, who's a psychiatrist based in America, conducted a trial which was sponsored by Eli Lilly, which compared haloperidol and olanzapine and brain scanned people for a year, followed them up for a year, and found that within 12 weeks there was evidence of shrinkage in people taking haloperidol. And over a year there was evidence of the same shrinkage in people on olanzapine as well, but to a slightly lesser degree. They concluded that what this showed was that olanzapine prevented the underlying brain shrinkage better than haloperidol. And they were obviously convinced about this conclusion because Eli Lilly then funded this study with macaque monkeys, which did the same thing, compared haloperidol, olanzapine, and monkeys that were treated without any drugs, and showed conclusively that the brains of these monkeys were smaller in the monkeys treated with olanzapine and haloperidol than the monkeys treated without the drugs. They were given some placebo injections instead. And then there's been a long-term follow-up study done here as well, which also suggests that there was a strong correlation between the shrinkage of the brain and the amount of antipsychotics that people were prescribed. Bipolar disorder has been, as I mentioned, has been another diagnosis which has been promoted by the pharmaceutical industry. And what they've been doing is trying to persuade people. The makers of antipsychotics, and the antipsychotics are the big blockbusters at the moment, the new antipsychotics like Zyprexa and Seroquel, they've been trying to get into the depression market because they know that there's many more people, out there with depression than with psychosis. And the way that they've been doing this, in part anyway, is through this diagnosis of bipolar disorder. So a lot of their advertisements have been about trying to persuade people who might view themselves as being depressed that actually they've got bipolar and therefore they need an antipsychotic. And at its extreme, this trend started to label children with what was called pediatric bipolar disorder. Going back a couple of decades, it wasn't believed that children could have bipolar disorder. It was thought to be something that only started later in life. But then there was this idea that pediatric bipolar disorder can be manifested in different ways from adult bipolar disorder. And this group at Harvard started to do trials with children, some preschool children, testing them with antipsychotics, diagnosing them with bipolar disorder. It turned out they were receiving enormous amounts of money from the pharmaceutical industry, which they hadn't declared. So just a few final comments. To take a step back again, I think it's useful to look at how this increase in the consumption of medications for mental health problems parallels general trends in the increase in consumption over the last half century, much of which recently has, of course, been fueled by debt-fueled consumption. And this debt-fueled consumption has led to rising rates of inequality, particularly the very rich getting even richer. And psychiatric drugs, I think, are an important part of this picture because they are a commodity that encourages people to identify, to see the source of their anxieties and difficulties within themselves rather than out there in society. They stop people asking too many questions that might be awkward politically. They also, as I suggested earlier, help to legitimize the control and containment of people who do not make very good and compliant consumers, people who fall foul of this system. So there's been, in England, a large increase in the use of the Mental Health Act, the forcible admission to hospital of people, but also the use of community treatment orders, whereby people are forced to take treatment in the community. And this parallels, of course, the massive increase in the prison population, both here and in England and Wales as well. So just coming back to the different models of drug treatment for a minute, I'm trying to I'm trying to suggest that there's a better way of thinking about what drugs might be doing when we use them for mental health problems, that we need to acknowledge that they're drugs, that they're psychoactive substances, and we need to understand those effects more. And when we do that, we can use them in a rational and more collaborative way and a more cautious way. Because the point about the disease-centered model that I think is so dangerous is that it assumes that drug treatment is going to be beneficial. Because, of course, if there's an underlying problem and the drugs are helping to normalize it, well, of course it's a good idea to take them. Why wouldn't you? The drug-centered model, on the other hand, by emphasizing that these substances are drugs, assumes that they might be harmful, and therefore you have to make a good case for using them. And I think I hope that I've shown you that I think it's only when we stand back from this literature that you're able to realize how we've got to this situation where we have a potentially dangerous and completely unfounded model of the way that psychiatric drugs work. That model has become the standard accepted way of understanding these substances and the basis on which they are used. It's only when we stand back and we start to look at the social and political factors that have been involved that we start to appreciate how badly deluded we have all been. Okay, thank you very much. I'll leave it there for now.
Thank you. I know a lot of people have questions, so raise your hand and you'll be given a microphone. We also have 19 people watching us online, including one person in Colombia, in the nation of Colombia. So you're welcome to send a question via email, too, if you're watching us.
Thank you so much for such a amazing and inspiring. I've been waiting years to hear you speak because I've been so concerned about this for years. Particularly, I'm an occupational therapist who's worked mostly a lot in the mental health field, and I see the effects of those antipsychotic medications, the apathy, the disinterest, the social withdrawal, and then I'm supposed to come and help people be motivated to engage in meaningful occupation when they're, in a chemical straitjacket. It's been enormously frustrating for me. A question I have is about this study that was done with the macaque monkeys, where they compared, haloperidol, olanzapine, and a placebo, and it was funded by who?
Eli Lilly.
What did they think about the brain damage associated with their precious drugs?
I don't know that they've made any comment, and they've not altered their information on the Zyprexa website, but to their credit, it was published. So at least they didn't try and stifle it.
And then it was repeated again. And it wasn't funded when it was repeated by Ho at all in 2011? Do you know?
I think that was a National Institute of Mental Health funded study, and that wasn't an animal study. That was a study following patients.
Okay. Thank you very much.
Thank you for your contribution.
Wonderful talk. I just wanted to get your take on, I've heard chemical imbalance like my entire career, trained on that. What's your take neurologically, like this chemical imbalance? Because I have a lot of speculation on it.
Sorry, what's your question? What exactly?
What's your take on chemical? Sorry, yeah, no worries. What's your take on when somebody approaches you and says, "Well, this patient has a chemical imbalance, so therefore we need some type of psychotropic intervention"?
I mean, my take is that there is just absolutely no evidence that anyone with any mental disorder has a chemical imbalance of any sort.
Right. That's precisely what I was hoping to hear.
Absolutely none. And that we should not be considering treatment on that basis. There are other reasons why we might want to use drug treatment, but we should not be justifying it on that basis. And if we're telling that to our patients, we're being dishonest, I believe.
Good evening. I'm Gail Brazum, the Dean of the College of Pharmacy. I guess I have to take exception to a couple of the statements you say. I do believe that we do have enough evidence in current literature to suggest there is a basis for the disease-centered model, particularly for some drugs that are psychiatric drugs. I would respectfully disagree that I think you've chosen studies that aren't more contemporary studies, and with now us having various models and having various targets for drug therapy, that we are demonstrating that some of these newer psychiatric drugs. The drugs I think you've talked about are the older generations of drugs, and we know that there are problems with those.
Do you want to give me some examples of what
Well, I think some of the new antipsychotics, some of the new, we've got, and I don't have enough off the top of my head those, but there's literature to suggest that these are done in peer-reviewed studies that aren't drug-funded, that are effective, and I think this disease-centered model assumes that in any drug, a drug in the United States to be marketed has to be there as a drug, is generally regarded as safe, and there are side effects. And that's why they're prescription drugs. And that's why we have pharmacists and physicians and nurses working in a team to help patients. So I don't think we should completely throw out the disease center model, particularly as we understand more and more about genomics and genetics and differences that they have in patients. I can see your point of certainly concern about some other drugs here, but I think you're misleading folks if you think that there isn't a basis from disease for some of the psychiatric.
Well, I would love someone to put the evidence to me for the disease-centered model. And I've been trying to debate with various biological psychiatrists for a long time. And the only one that has debated with me is Ian Reid, I think he's called, from Aberdeen. And he couldn't come up with anything that convinces me that there's any evidence that that any drugs have disease-centered effects. I mean, the evidence about the atypical antipsychotics, the theory is that they're working on dopamine receptors, possibly on 5-HT receptors in combination with some of them. Some of them, that was an idea around in the 90s, seems to have faded a bit. And as I say, there really isn't any evidence that there's any abnormality in dopamine in schizophrenia. There are millions of studies, and some of those studies are going to maybe come up with some evidence that, one or two might come up with some abnormalities in some 5-HT receptor here or there, but overall there's no consensus that there's any abnormality in that system either. Where I think you make good points, and it's important, is yes, we do know quite a lot about the adverse effects of these drugs, and I agree with you that pharmacists and other people are very useful, and it's extremely important that we discuss that information with patients. And some of those effects have been considered by regulatory agencies. So, for example, the FDA, the makers of Seroquel, can't remember who they are from a minute, the makers of Seroquel applied for a license for the treatment of depression for Seroquel, and the FDA decided that the adverse effects of Seroquel outweighed any possible advantage there would be. So they didn't grant them that license, not for the primary treatment of depression anyway. So yes, there are some safeguards, but they did allow Seroquel to be prescribed as a treatment if other treatments have failed in depression or first-line treatments have failed. So they still opened up potentially big market, but yes, there is some. Genomics, I think, is very interesting and important. People respond differently to drugs. And partly what I'm making a plea for is that we do more research and understand better what what drugs are doing to individuals, and part of that is understanding how people's genetics influence how they metabolize things, therefore how they experience things, what different effects they might have.
I think where you're going to see the differences is where it's not necessarily how the individuals are going to handle the drugs. It's going to be as we understand the disease-type drugs. A particular patient's going to have a genetic form. Now, it's going to have to be very specific types of genes, and I think we're starting to do that as we are able to do that, as we're able to map the areas of the brain. I think that's where and so I think our disease center model we can't throw out, because we are probably going to treat patients as a function of their type of disease. We're already doing that in different cancers. I think the brain and those are only a matter of, this is a decade of the brain, I suspect that we're going to see tremendous advantages and that we are going to be able to treat the disease, realizing that drugs always will have adverse effects. And we're trying to optimize the beneficial effects with the adverse effects.
So there's a fact that we do something, and then there's a rationale for why we do something. I really appreciate what
Can you speak up?
Yeah. So there's a fact that we do something, and then there's a rationale that we do something. And I think what you spoke to about today is really the rationale for why we prescribe certain drugs for certain conditions. Can you speak to the fact